upon our last speaker before our first break, Dr. Michael Brauer, who will be telling us more about environment and health. We've heard from each speaker the importance of air pollution, and I know from Michael we'll hear even more. Welcome, Michael.
So thank you very much, and for the invitation. It's a pleasure to speak here. And I also wanted to thank you, Salim, for the collaboration. I think, I know it was 2008 when we first started talking, because I was on sabbatical in Hawaii, which I still think about all the time. I want to thank you for your patience, because it's just now that I think this collaboration has been bearing fruit in looking at the role of environment in PHRI. So I will give you a little bit of overview from the global burden of disease. A big disclaimer, even though I work on the global burden of disease, I characterize it as a work in progress. It's a continual work in progress. It's never right, but I think it's sort of the best information we have to benchmark and in terms of relative comparisons among different risk factors. So what do we know, or what do we estimate from the global burden of disease? So one thing I think to be very clear about is that of the overall disease burden that is being estimated, only about 50% of it is being attributed to risk factors. So there's actually a lot of room for more understanding and a lot of encouragement for especially the younger generation of researchers to continue doing that etiologic research. Of that 40% or 48%, the environmental contribution is about 25%. So in total, we're attributing about 12% of the global disease burden to environmental risks, and that's using a DALY measure. If we look at mortality, it's a little bit more explained or more attributed, about 15% of the total. So by no means do we think or claim that environmental risk factors are the most important or are the only thing to be concerned about. But I think, as you've heard from some of the other speakers, there is an enormous opportunity for these sort of upstream risk factors that if you can reduce them, everybody essentially benefits. You really avoid any of the problems, actually how to deliver a solution to an individual person, or how to deliver even a behavioral intervention. So this is the way these risk factors stack up relative to some other ones. So you can see, for example, air pollution. This is the combination here of both household air pollution and ambient air pollution is a leading one from an environmental perspective, but certainly trails high blood pressure, tobacco, plasma glucose, and again, if you believe this, dietary risks. Overall, the Lancet Commission on Global Health suggests that the role of pollution in general accounts for around 9 million deaths per year. If you look a little more detail at these environmental risk factors, so the leading one would be outdoor air pollution, particulate matter, and outdoor air, followed by household air pollution. Then you have unsafe water, lead, unsafe sanitation, and hand washing. The trends of these are quite different. So you can see, for example, household air pollution, it's decreasing, which is a good thing, and it actually tracks quite well with a measure of socioeconomic development, as you can see on the right there. So as economies and countries develop, people move away from polluting fuels to cleaner fuels. Similarly, for water, sanitation, and hygiene, that tracks quite well with development. So that's also decreasing. The one here that really isn't decreasing and really is increasing is outdoor air pollution. And again, on the right, you can see that the pattern with development is not quite as clear. What happens actually is very low-income countries, actually outdoor levels of pollution are on the lower side. As they develop, we get an increasing levels of air pollution, and then at some point, there's a turning point, and conditions start to improve. And that, for example, is where China is right now. So since about 2013, actually, ambient air pollution in China has been improving, and we're, again, estimating decreases in attributable burden from ambient air pollution. India, on the other hand, is still on that upward trajectory, where pollution is getting worse and the attributable disease So what do we think we know, I would say, about air pollution and health? I was telling Richard last evening that even though I've been studying this for more than 30 years, I still question the science, and I think it's important to actually question it. For one thing, though, I think it's very clear, and you saw these very small relative risks, for example, that Professor Jha just presented. The risk to an individual is small, and it better be small, because we're all exposed to it. But what makes it potentially important is the large exposed population, which then translates into this large population level risk. From studies done now in hundreds of cities around the world, these are ecologic daily time series studies where you're looking at counts of pollution or counts of deaths relative to daily fluctuations in pollution. We see very clearly that on days with worse air quality, more people die. These deaths tend to be occurring not in people that are likely to have died 2 or 3 days later anyways. They're primarily occurring in deaths out of hospital. So this is the latest analysis. This is done now in 652 different cities around the world, so China, several in Africa, South America, Western Europe, and North America, and you basically see this consistent relationship in that days with higher air pollution, you get higher death counts, and primarily driven by cardiovascular deaths. There's this interesting phenomenon that the slope of that relationship, so a normalized change in mortality for a change in air pollution is steeper in the higher income countries that are at the lower end of the distribution. And I think this is still a rather perplexing phenomenon. So essentially, the lower levels of air pollution give you sort of a greater relative impact. And I'll come back to that. Looking at more of a chronic exposure, we also have now many studies that suggest that in more polluted areas, people will die earlier than those living in less polluted areas. And so here's one example from a study that we've done with China CDC, looking at nearly 200,000 men over the age of 40. And we see this relationship both for non-accidental mortality, but also for cardiovascular mortality, ischemic heart disease, stroke, COPD, and lung cancer, adjusting for quite a large number of both area level covariates and individual level covariates. And in this example, there's 15 years of follow-up. This is a project I've been involved with for several years now in Canada, where we are taking advantage of some really wonderful pieces of linked data. 2 sets of linked data here. One is what we call the Canadian Census Health and Environment cohort. So 20% of the Canadian population is given a long-form census. So this is a complete random sample of the Canadian population. In fact, if it's illegal not to fill out this census form. And these have been linked to death records, and we have 3 waves of these cohorts, essentially, totaling about 1.5 million deaths, so over 150 million person years of follow-up. The follow-up goes anywhere from 15 to 25 years, depending on the wave. So this is nationally representative, and we have many, many socioeconomic and area level covariates. What we're missing is rather limited information from those cohorts on individual level risk factors, because that long form census is asking about things about the household, but not very much about the individual. We also have the ability we've linked those to tax filings, which actually tell us where people live every year, or at least every year that people file for taxes, which most people in Canada tend to do. We balance now with I would say a smaller but deeper cohort, which is the Canadian Community Health Survey mortality cohort, which is smaller, about 1 million people, 50,000 deaths, but it has much more depth. So we have self-reported information on health behaviors, BMI, diet, physical activity, smoking, alcohol, etc. And all of those cohorts have been linked to satellite-based estimates. We're now doing this at a 1 kilometer resolution. We link that with all the available ground monitoring. So really getting actually very, very good estimates, especially tailored these estimates for Canada specifically. So we're getting quite small errors in the satellite-based estimates, but it does allow us to study the entire population, including the population that is in rural areas where there is no sort of ground monitoring or gold standard monitoring. So we can see we have these elevated risks. They're very small. Again, this is per sort of 10 microgram per cubic meter increase. Some are around a 5% increase. Interestingly, in the Canadian Community Health Survey, when we add more of these individual covariates, the risk increases. Does not decrease. It increases, so we're up at around a 10 to 12% risk. Those are linear estimates. This association does not appear to be linear, so this is a way that we try and look at the non-linearity, and I would say this is very complex statistically. I'm not going to explain it to you in detail, but what you can see, I think, from all of these cohorts is, again, this sort of curvilinear relationship. Two things I'll point out. Again, that point that the association seems to be steeper at the lower end of exposure, and there's really no evidence, even if you're looking at the lower confidence interval, of a no effect threshold, or if there is, it's very, very low, generally below the levels that we would typically see in an urban area. All of that's for non-accidental mortality, but we've done the same kind of thing in earlier analyses for cause-specific mortality. And while those relationships or the shapes of those relationships do differ somewhat by cause of death, they all tend to display something like that curvilinear relationship. Some of them are a little bit more linear than others. I won't go into any detail, but when you start seeing things like effects on the stroke and ischemic heart disease of something you inhale, the obvious question is, how does that happen? How does something you breathe in start to affect your vascular system? I would say over 15 years now, there's been really extensive mechanistic research to back that up. Not just animal models and cellular models, but even controlled exposures that are short-term. So we're only exposing people for several hours, but where you can start to see some of these indicators, for example, of systemic inflammation, and even epigenetic impacts on gene expression after an hour or so of exposure. These are the results that are just sort of been submitted for PHRI. The studies that I showed you were just a few snapshots. Importantly, with the exception of a few studies in China, we don't have a lot of studies from high pollution environments. So the bulk of the information, especially from cohort studies, is from locations like Canada, Western Europe, and US, where concentrations are obviously lower. And when you then start to project, for example, an estimated disease burden, the bulk of the disease burden is coming from countries like China and India, Bangladesh, Pakistan, that are much higher. We don't actually have information there. So PHRI is actually an example, one of the rare examples where we can actually have been able to study this. And what we are finding is that, again, small increased risk. We do see increased risk across the distribution in PHRI that are not very different from what we're seeing, for example, in that study in China, or even in the study in Canada. And again, the advantage of a study like PHRI is extensive covariate adjustment. We've also looked at household air pollution in PHRI, and I would say there, again, we see relationships. This is one of the first examples of impacts on cardiovascular mortality, directly measured cardiovascular mortality related to household air pollution. We are seeing evidence of increased risk for cardiovascular events, mortality, as well as respiratory disease in the PHRI study. This is just looking at a measure of did people or did they not use polluting fuels. We've been following this up with very detailed measurements where we can actually provide a quantitative estimate and then apply that to all of the PHRI participants. And interestingly, PHRI has also provided a very nice example of that trend of decreasing exposure. So we have longitudinal follow-up, 9 years of follow-up, where people were asked about their fuel use. And we've been able to track that fuel use and actually look at determinants of the fuel use. So what are the factors that actually led people to change from a more polluting fuel or to a cleaner fuel? So that's been an interesting bit of analysis also that we've taken advantage of in PURE, where we've recently published. Also, just to add, perhaps of more relevance for the future, that we have now increasing studies that show that in the most polluted areas of cities, there's also an increased risk of dying. And here's sort of one of my favorite studies. So we did this in Vancouver, and this is looking at a linked data cohort of about 500,000 people, so adults over between the ages of 45 and 85. And we had an interesting example also where we tracked the residential history again. Every contact with the healthcare system is recorded, and you're asked to update your address. So over a 5-year exposure period, some of the people moved. And people moved either closer to a major road or farther away from a major road. And I'll just point out on the far left here, this is just looking at 50 meters close to a major road or 50 meters away from a major road. But the same sort of pattern shows up for different measures of exposure. And we've also done this now with air pollution estimates as well, and particularly black carbon. So the baseline here is people who never live within 50 meters of a highway. The people who, during the full 5-year period, were living the whole time close to a highway, they had more than a 50% increased risk of subsequent coronary heart disease mortality. But the interesting group is this group here at the bottom who moved away from traffic during that period. And their risk dropped almost down to baseline. So it's like smoking cessation. This is pollution cessation. Now, from a policy perspective, we can't move everybody away from roads, but we do certainly have examples in the world where we've moved roads away from people. Now, I'm not going to present any of this evidence today, but there's also a number of natural experiments that have been done for air pollution, which I think also are an important piece of the evidence. So, very famous study done, for example, in Utah with a steel mill closure. So the steel mill was on strike for about a year, and you could see in that community both the levels of pollution went down, but also the rates of mortality went down during that period, went back up when the strike ended and the steel mill began operating again. And there are a number of other natural experiments like that. So this is some work that we've done for the latest round of the global burden of disease, and I thought this would just be interesting. I showed you the results that we just published or submitted for PURE. Where does sort of PURE fit into the global data? So what we're doing here, these are the green are studies of outdoor air pollution, the red are studies of household air pollution, and then we also have a number of studies of secondhand smoke that we've converted or estimated into a PM2.5 concentration. This is now sort of looking at a full global range of exposure. So you can see this sort of phenomenon on the right-hand side of these outdoor air pollution studies generally tend to have higher, a lower level of exposure, the higher the level of relative risk. And so PURE is an example where we've got kind of a higher exposure phenomenon. And the studies are sort of, fitting this relationship that we're using to estimate disease burden quite well. And if anything, are somewhat lower, again, than what we see in sort of the higher income, lower pollution setting. So this is for stroke. Sorry. That's relative risk. Yeah. Yeah. And then this is for ischemic heart disease, again, and really a similar phenomenon. Just to point out, in this example, many of you are familiar with the global burden of disease. When we've done these sort of estimations in the past, we've used active smoking data. Using sort of a new Bayesian meta-regression approach, we're actually able to fit the data quite well, and not using the active smoking information, which I think avoids some problems in terms of sort of interpretation. So that's a sort of a deep dive on air pollution, but I guess what's missing in terms of the environment. So as I said at the outset, we're only attributing about 50% of the global disease burden to risk factors in general. Is there anything missing for the environment? And it depends on who you talk to. But certainly there are people that are interested in both additional diseases linked to air pollution. So in this next cycle, the GPD, we're adding reproductive outcomes. We've seen pretty consistent evidence on impacts on low birth weight, perhaps less consistent on prematurity. There's growing literature on autism, dementia, and then a whole host of other pollutants, heavy metals, toxic chemicals, pesticides, for example, that there aren't now being attributed to disease burden, but could be. And then also emerging chemical pollutants such as neurotoxins and disrupting agents, for example. The WHO has sort of done, I would say, some very crude analyses, and they would conclude that unlike the sort of 12 to 15% that the GPD is estimating, that around 25% of all global deaths are linked to the environment, and that's extending to include things like climate change, the role of the built environment on physical inactivity, noise, and UV radiation. So just in the remaining time I have, let's think a little bit about the future. Climate change is obviously going to affect all facets of society. Whether it's going to affect health, I would say is unclear. There are certainly many indirect pathways by which climate change can affect health. I would say some of the most important things would be things like migration of populations, food security, etc. But we also have some evidence or some suggestions of direct effects related to weather. And the big one would be sort of suboptimal temperature. This is an analysis a few years ago led by Antonio Gasparini and colleagues at the London School of Hygiene. I think it's important to point out that even though the media and certainly the public attention tends to be focused on heat events, the vast majority of temperature-related mortality is due to cold, and not even extreme cold, but actually moderate cold. So, for example, homeless populations in Canadian cities, as just one example, but you have many populations spread around the world whose shelter does not fully protect them from moderate cold. And we're starting to now include this in the global burden of disease. So this is short-term temperature. This is not climate change, and I think it remains to be seen whether, as the climate warms up, what is the role of temperature? Are things going to get worse? Are they going to get better? We certainly know that people adapt to temperature, both physiologically, but also we have large behavioral or infrastructural adaptations. So, for example, in the US, the fatality rate related to temperature due to extreme heat has dropped dramatically over the last 50 years, and that's mostly explained by increasing prevalence of air conditioning. And so as the climate warms, we will start to see these structural adaptations. So I think it really remains to be seen what's going to happen with health. Let's see if this works. The other thing, a major trend that is relevant for the environment is urbanization. So this is just an image of lights at night. Presently, about 55% of the global population lives in cities. By 2050, that's going to be 70%. And cities really are going to absorb the entirety of all population growth in the future. So Canada is now 82%, similar to most high-income countries. And in the next 40, 50 years or so, the whole world is going to be highly urbanized like Canada is. So a pertinent question is sort of what is healthy urban form, what is healthy environment? And perhaps to maybe even flip this around and think about, can we think about designing, modifying our cities in a way that they are health promoting and not unhealthy? So some of the things that we're looking at, in addition to things like air quality, are also noise, access to natural spaces, such as green or blue spaces, the role of the built environment on physical activity. Prabhakar mentioned, for example, walkability, how conducive is a urban area to getting around by active transport, such as walking or cycling. traffic injuries and other injuries, and then social interaction, social capital that could be enhanced, or actually could be diminished depending on how you actually design urban areas. So just some work we've done again in Vancouver. We've looked at sort of joint exposures to air pollution and noise, and in this case we tend to see independent effects. So even though these have somewhat common sources, the sources act a little bit differently. And you can, just for example, an idling vehicle at an intersection creates the most pollution. It creates no noise at that time when the vehicle's moving. It actually creates the most noise and the least amount of pollution. Traffic-related air pollution in relation to childhood asthma. I'll skip through this, but right now that's not included in the global burden of disease, but we're estimating about 15% of global pediatric asthma burden related to sort of a different form of air pollution that's related to traffic variation, variation in traffic pollution in cities. I mentioned earlier dementia. There's a large study that was done in Ontario. We've replicated it now in British Columbia, showing associations with traffic proximity and traffic-related air pollution with measures of dementia. I mentioned earlier green space or access to nature. So this is something that I just completely did not believe the first time I saw this. But I think there's like really a growing literature that is really actually quite well developed and supported by both theory and quite a lot of mechanistic work, surprisingly, on access to nature or greenness and measures of health. This is just an analysis, again, done in that Canadian Census Health and Environment cohort, looking at greenness and mortality. The obvious question you would ask is, well, don't more wealthier people just live in greener areas? But in this study, actually, there was increased mortality protective effect seen for those of higher income and higher education. And there's multiple pathways that probably vary by disease as well. We've started to look at this again in relation to air pollution, noise, and walkability, and we continue to see this sort of protective effect of greenness. So just to wrap up, very last slide is how are we going to deal with this? So urban environments are incredibly complex. If you think about multiple spatially correlated exposures, it's very hard to characterize them well. So we started to use the wealth of imaging information that's available globally, both satellite, high resolution satellite imagery, where we're now getting at actually a 1/2 meter resolution. And also things like street view images, so the millions of images that companies like Google are taking around the world. And you can use these in a machine learning or AI format to actually train these images to predict environmental exposures and then characterize the exposures both over space and time. So thank you very much.
I'll ask our speakers to come up to the panel. We'll do 10 minutes of questions before the break.